The second segment is a case study from the Berkshire West Rapid Response and Reablement team and highlights a scenario which I'm sure many of you will be very familiar with. The case study describes how to work with the care home staff, with patients themselves and with their families to ensure that all the necessary information is captured and uploaded to allow the best care for these patients. With people living longer and with more complex needs, a much wider variety of practitioners are involved in their care. This means that communication is essential and that information really needs to be provided so that all these professionals who may not be present at the time of writing the care plan are able to use the information that's contained in the care plan to ensure that they are providing the care that the patient would want for themselves. High quality and properly recorded care plans can be very useful in situations where the care staff themselves have formed relationships with the patients and where emotions may be running quite high in urgent care situations. These care plans also provide confidence for the care home staff that they are fulfilling the requests and the requirements that the patients themselves have made at a time that they were able to make their own decisions. The other point that's really important with regard to care plans is for the professionals to understand the context of the requests that are put in the care plans, ensuring that the patient's wishes are complied with when they are brought in from outside. I believe you will find this film informative and a useful reminder of the crucial role that care planning has in the care of all patients, particularly in end-of-life settings.
I'd like to introduce myself. I'm Layla Bart. I'm one of the community care elderly consultants. I originally started in October 2015. It was a brief start. 6 months later I took maternity leave and I'm just back and fully into the swing of things. So when I started my job here at Berkshire Healthcare Foundation Trust, it was part of the rapid response and treatment service into care homes. A little bit about service. It's essentially an admissions avoidance scheme where if any residents deteriorate from coming well, and they're teetering needing hospital, either the GP or the care home can contact the rapid response team via the hub, and within 2 hours, essentially we would be there assessing the resident and making a plan. And really, for us, advanced care planning is essential, and it just helps us to make decisions quickly, and also to build on those relationships with the families and the residents and the care home to formulate plans, thinking about the residents as number one. So, Jeremy's already explained the advanced care planning. So, it's a voluntary process. It essentially should involve the individual, but we know that not all our residents have capacity. So really, the earlier to have advanced care planning, the better. And it should involve care providers. It doesn't have to be the GP. It can be the district nurses. It can be the community nurses. It can be specialist nurses, even in the hospital. And also, it's preferable with the consent of the family, with the consent of the resident. It should involve the family and their friends, so that they're all involved in the process. And it should be really to find out the residents' concerns and wishes for their future care, and to talk about their chronic conditions and their expectations of their chronic conditions, and about informing them of the journey they potentially may take in the future, and finding out what their wishes are when they encounter those stumbling blocks. And it's really to find out what they want, where they want it, and how they want it, and also to let them know about the options that are available for them. And it's important that they're aware that it's not set in concrete, it's something which should be reviewed as things change. So, as Jeremy said, when should it be happening? Sometimes a life-changing event, if something's happened in the family, like the bereavement of a spouse or a close friend might prompt them wanting to discuss their future care. It might be following the new diagnosis of a life-limiting condition or a diagnosis of a chronic condition. And it should be assessing their individual needs. Also, if they've had multiple recent hospital admissions or frequent GP call-outs or needing more and more services, these are the people that we should be advanced care planning with. Documentation, there's nothing really set in stone about where we document things, but actually it's important to share it with everybody who needs to know, and in a way from the beginning to let the resident and the families and the carers know that it's to share knowledge amongst the people that will be dealing with the resident. So it's essential to be in the care home. I think that's really priority. The care home needs to know what's going on. They need to be able to access it quickly if they need it. It should be in the GP records, and Adastra is really useful. It's something that we've called upon many a time. So I'm going to give you some examples of advanced care planning and where it's been helpful and where it hasn't. So we got called several times to see this gentleman in one of our local nursing homes. He was 90. He was suffering with recurrent chest infections. And once again, we were referred for another aspiration pneumonia. He had a past medical history. He had first-degree heart block, CKD stage 3, which a lot of our residents have. He was known to have advanced dementia. This gentleman was functionally, he was bedbound. He was on a modified diet. He couldn't communicate his needs. He couldn't communicate. Like I said, he suffered with recurrent chest infections and he had a history of asthma. Now, as mentioned, so bedbound, hoist transfer into the shelves, the best we could get him, that the care home could get him. He needed full assistance in personal care, doubly incontinent. So really, it's laying it on that this gentleman, he functionally needed a lot of help and he was frail. So, as far as the advanced care plan worked, when we went into the care home, he had a DNA CPR in situ. He's had anticipatory medications for over a year, and there had been a verbal agreement that he was not for hospital admission. However, several calls to 999 have been made recently, and it caused so much upset between the ambulance service, who put in a formal complaint to the care home, what you're doing, the care home saying, but our guideline, nothing's in writing. So it shows you where an advanced care plan had been started, but it really hadn't been integrated within the care home and with the resident. So the care home, so he basically, the gentleman was having problems with regards to his swallowing. We knew he had an impaired swallowing, he was on a modified diet. He was suffering with the effects of somebody's swallowing who was deteriorating. He was becoming, every time we would get another chest infection, he was becoming more unwell and more difficult to treat. Even though that there is what we think there are ceilings of care, and the fact that he's got DNA CPR, but it doesn't say when do you stop treating antibiotics. It doesn't say when we could give intravenous antibiotics. So the rapid response service can, as mentioned before, it's not hospital admission avoidance. We can give enhanced medical care. We can give intravenous antibiotics. But is it appropriate for everybody? Probably not. But nothing had been really laid out for this gentleman. Now, as I mentioned, the care home had called 999 3 times for choking, and he'd been admitted to hospital on each of these occasions and sent back. Like I said, the ambulance service had made this formal complaint, and so really the relationships were breaking down between the care home, the resident, the family, SCAS. So the problem was basically that the care home knew that he wasn't for resuscitation. They knew he was not for hospital admission avoidance. That was in writing. Oh, well, the not for hospital admission avoidance wasn't in writing. That was a verbal thing between the GP and the care home. But they had this weird policy about choking episodes. Now, we would know that choking episodes that you start basic life support. I mean, not for resuscitation doesn't mean not for looking after the resident and treating when he's alive. But they had integrated in their policy that if he was to choke and he suffered a cardiorespiratory arrest, it doesn't matter if he's got DNA CPR, they would resuscitate. So if that had been known earlier, maybe this could have been changed, or a better advanced care plan, formulated for the care could have been made. So what we did was, once we treated the gentleman for his aspiration, started treating the gentleman for his aspiration pneumonia, we decided we arranged a meeting with the care home, the family, so his next of kin, which was his wife and his daughter. Obviously we couldn't involve him because he didn't have capacity, and at the time he was actually quite poorly, and we sat down and we talked about dementia. The family knew that he had dementia, but they didn't know about the process and what would happen as his dementia progressed, which he's, at this point, he'd reached the later stages. So we talked about the fact that his swallow has deteriorated, and this due to his advancing dementia, and that the evidence about artificial feeding and nutrition, and the fact that speech and language could assess him, but and say, advise about risk feeding, but we explained what risk feeding was. And so his wife then said during the meeting, she goes, well, actually, he wouldn't want this. I mean, this isn't the quality of life he would have wanted. I've known him, I've been married with him for 50 odd years, which made making decisions a lot easier. So by that point, with regards to the swallow, we decided that risk feeding was the most appropriate thing for him, and that if he wasn't liking his thickened fluids, we weren't going to make him starve to death or dehydrate. We would then maybe thin the fluids up, accepting the risk that quality was better for him. Then we went on to what do we do if he deteriorates? Well, this gentleman had been on our books 2 or 3 times in a short period of time. He'd had several courses of antibiotics. And it looked like he wasn't really improving. He was getting further infections quite frequently. So we discussed with his wife, and we decided that we would try oral antibiotics, and after 24 to 48 hours, if things weren't getting better, that we would start end-of-life care in the care home, which was something that had been discussed when he entered the care home in the first place. With regards to intravenous antibiotics, because he was so frail, and he was getting distressed every time anybody intervened, it was agreed that intravenous antibiotics wouldn't be the right thing for him, and it wouldn't really prolong or improve his quality of life. And so, with end-of-life care, I revisited it with the wife, and she confirmed that he would have wanted to stay in the care home, where she actually lived in the care home with him. So that meant she could be by his side if needed to be. And we put in the anticipatory medications were already in place. I just at that point explained what each of the anticipatory medications were and how they worked, so that she knew what was going on. And if it got to that point, she wouldn't have to worry about seeing a syringe driver or seeing the nurse give subcutaneous medications. And for the care home, we visited the choking. So he will always be a choking risk, but they're not going to be giving him big chunks of meat every day, not, because as part of his speech and language assessment, he was meant to be on a pureed diet. So it was more about basic nursing, sitting him up when they feed him, continue his modified diet, but if in the event of choking, basic first aid, back to that, possibly Heimlich, obviously. And if he was to have a cardiorespiratory arrest, at that point no CPR should be made, as it would be successful in the first place, but also it would cause greater long-term harm for him. And we put that in writing for the care home in their notes. And then, following from this, the care home are reviewing their policy. Obviously, you can't go against, well, you can go against the GNS CPR, but it's there for a reason. So that was one example where actually the advanced care plan helped, because he was then treated again for a chest infection and oral antibiotics. He didn't really make much of a recovery, and he's been kept comfortable in the care home on end-of-life care, and everybody's happy, wife, daughter, care home, and the care home staff feel more confident in looking after him, know that they're doing the right thing. Do you have any questions about that case?
How were you called out in the first place? As a RRaT team?
Yeah, as a rapid response team. And then when the nurses came out and saw that there was so much confusion about his his care plan. They then called on me to review his advanced care plan with his family. And generally that's how I'm getting involved with the advanced care plan at the moment, is that every time somebody comes on as an acute case, if it looks like the advanced care plan isn't really set in stone, or there's some questions about it, or it looks like things have changed from when they had their last advanced care plan, we review it then.
Do you then send a copy of that to the GP?
Yes. So it comes in a letter, and there's a lot of waffle in the middle talking about his basic information, but at the very bottom, at the very top, there'll be medical conditions, his current medications, and the title advanced care plan, and what the new decisions are. And I've been cutting and pasting that and putting it on Dastra at the very bottom with the date. So hopefully that should help. So that's that case. I wanted to give you another case where advanced care planning, if it was put in place, could have actually saved what I think could have saved an admission and been a better outcome for the resident. So we get called, so a referral comes through the hub for a 91-year-old lady who is in a nursing home, normally mobile with a frame, requires some assistance with personal care, can communicate verbally, occasionally confused but can express her needs. So she's somebody who I think probably could have made decisions. So she has a past medical history of vascular dementia. She had a AAA in 2015, which was diagnosed in hospital, which was meant to be scanned on a 3-monthly basis. So 2015, and I'd like to say we're in 2017. So all these cases are falling on maternity leave. Osteoporosis and tardive dyskinesia, that's her past medical history. So she had, when we got called, we had a look at her advanced care plan in the care home, she had a DNA CPR in situ, but nothing else. No information about her wishes about hospital admissions, nothing about her AAA and what we do. So she referred to the rapid response team as being vomiting, sleepy, not really taking much in. She had a long, when we questioned the care home, she had a long history of nausea and vomiting, had been investigated but no cause had been found. But now she was complaining of lower abdominal pain radiating into her back. So alarm bells were ringing. So, and when they assessed her, she was unwell, she was complaining of severe abdominal pain, she had this pulsating AAA, and that, so what next, what happened next? So her normal GP wasn't available. The GP that was liaised with knew that it said on the records, it says that she has AAA, it's meant to be scanned, but there's no information beyond that. And there's no plan regarding what to do with AAA. This was the one where the GP advised to call 999 and admit that a lady was admitted into hospital. Now, the questions was if there had been an advanced care plan, so which would have been prompted by that hospital admission in 2015 when they picked up this AAA. Some things could have been pre-agreed. It may be that she wanted surgery, we don't know. It may be that she was a candidate for surgery, we don't know. We don't know about anything about her wishes, what she would or wouldn't have wanted. But given the fact that she's not 91, but because she's got dementia, she's frail, the likelihood of surgery was probably low. But nothing was documented, and so this lady had to be admitted. It could have been that this lady had urosepsis, which we could have treated in the care home quite easily. So it would have been helpful if there was a bit more information for us as a rapid response team, because we have to make these decisions fairly quickly, whether to admit or to treat in the care home. I think there was a missed opportunity because, as Jeremy mentioned, the community pharmacist does medication reviews and goes through from care home to care home with the GPs, going through patients' medications on using stop-start. So it could be something that could have been picked up then and discussed, what unfortunately was missed. So she had a potentially life-threatening condition. It wasn't being monitored. We don't know what was there. in plan for her future. And it definitely was a potential for end-of-life planning. So this lady she's still in hospital, so we don't know exactly what the outcome is. But once again, she's admitted, she's not vaccinated. So that, actually, yes, sorry, there's some changes. So she's admitted to hospital, she's not vaccinated for AAA, but she's developed a hospital inquiry pneumonia, which potentially we could have prevented if she'd stayed in the care home. We don't know. And like I said, she's still in hospital now. Any questions about that case? So I can quickly go through one final case.
Do you have any, I just want to ask about that, because the missed monitoring of her aneurysm.
Yeah.
Is there any way that, have you come across any simple way to kind of remind these kind of things, because it's the sort of thing that does fall off gets missed?
It's difficult. I think if this lady probably would have fitted into the category of somebody who should have had an advanced care. I mean, she was on a DASTRA, so she would have had an initial advanced care plan. Yeah. And all of her medical problems were there on a DASTRA. And they should be reviewed within 6 months to a year. Is that right, Jeremy?
Theoretically.
Theoretically. So there are opportunities there to.
But if you don't go through and read all the documentation, and if the aneurysm hasn't been put on as a read code, or from a hospital letter, it's very easy to miss those kind of things.
Yes, but in this case the aneurysm was there. It was on the GP, so it was got from the GP records.
Yeah, but usually aneurysms are monitored yearly.
Yeah.
Not 3 months.
This probably wasn't a discharge letter, if it was.
Yeah. I think it's a
say for a 91-year-old so they probably should have said if they haven't. Either they've said it and the GP didn't put it on the or they wasn't put, they should be saying no further follow-up.
Yeah, it's difficult. It's just a shame because you just think with advanced care planning we could have known what she wanted.
But I must say, when you see that discharge letter, the cluster is not always in your mind.
No.
The transfer.
And this is why, in reality, hospital admission should prompt thinking about advanced care planning, reviewing the situation, has something changed? Because in a lot of their cases, when they do get admitted, they're functionally, they decline significantly by the time they're discharged. So they're virtually a different person to what they were like before they came in. So this is where I feel I'm quite proud of this case. So he was a 95-year-old gentleman in one of our nursing homes. Functionally, he was frail. He bedbound, Zimmer-frame. Oh, actually, he wasn't Zimmer-frame transfer when I saw him. He was actually hoist transfer. He was doubly incontinent, unable to verbally express himself, unable to communicate his needs. His appetite had been poor. He had been losing weight over some time. I think the GP was fully aware of him and had tried advanced care planning, and this is where maybe if there are cases which are difficult, maybe calling on one of the community geriatricians to help with the advanced care planning might be a good idea. So he had vascular dementia, he had CKD stage 4, nearing CKD stage 5. He was known to the renal team. A decision had been made 6 months prior that he wasn't for renal replacement therapy, and that decision had been made between the renal consultant and the son. He'd got non-Hodgkin's lymphoma, which he fully recovered from, hypertension, and he was impaired hearing. So that was him. He had no advanced care plan, and it wasn't through the GP not trying for this case. He'd come under the rapid response service because of diarrhea and vomiting, which he fully resolved, but the nurses said, "Oh, Layla, do you think you could try an advanced care plan this gentleman?" So I went in, I assessed him. He was very frail. Examination findings weren't really amazing. So his normal, the baseline GCS was 11, and that was more due to communication, his systolic murmur, but there's nothing really exciting. He was cachectic, which is important to know. So I arranged a family meeting with his son. I introduced myself, explained who I was and what I did, explained the rapid response service, and explained how I'd become involved with his father's care, because I think it was nice to help build a relationship with the son. I explained about the rapid response service and the limitations of what we could offer. He was quite pleased. He said that if his father deteriorated, he would want him to be looked after in the rapid response service. However, he wanted, basically, when we talked about hospital admissions, he wanted his father to be admitted to hospital no matter what. He wanted his father to be fully resuscitated in mental cardiorespiratory arrest. And it took a good hour, and so advanced care planning can take a lot of time. It took a good hour of explaining what resuscitation was, explaining when we do it, explaining the outcomes and why in certain cases it would be futile. And also taking part of that decision away from him, I think, helped. Him thinking that he was making the decision not to resuscitate, I think, probably helped us actually come to an agreement. So he went away to think about resuscitation and to take in all the information we talked about. And we also talked about hospital admissions. And I said, well, if you're admitting him because he's got because of his end-stage renal failure, you're going to send him to hospital for the renal consultants to say we can't do anything, because we already know we can't do anything. So he would be there for end-of-life care in a hospital. Is that what you and your father would want? And at the end of the first meeting, we decided that if his father was to deteriorate and it was for a reversible cause, which the rapid response he couldn't do in the care home, that he would be for hospital admission. But if it was due to his end-stage renal failure, that he should be for end-of-life care within the care home. And then I followed up that meeting a week later, and I phoned the son. I said, look, have you had a think about resuscitation? And he said yes, and we put in the DNA CPR in the care home, which was really handy, because a couple of weeks later, so a couple of weeks later, he was referred yet again with an episode of vomiting, and he hadn't been eating or drinking. He was assessed. We initially put him on subcutaneous fluids. The reason we put him on antibiotics was, I think, more for the son, really. His blood test showed mildly raised inflammatory markers, but clinically, when you examined him, there was no real evidence of where the infection was. He had a long-term catheter in, so we'd sent off the culture. So we gave him some antibiotics. The ceiling care was oral antibiotics at this point, so we gave him liquid antibiotics. And I followed my assessment with a quick phone call to the son to say, look, your father's back on our books. I'm really concerned. The next 24 hours is critical. I think he's probably dying. And I worded it that way, and I said, we're giving him fluids to see if he perks up, but I don't think this is the long-term solution. We're giving him antibiotics, so if it is an infection he perks up, then that's fine, but I suspect that this is his end-stage renal failure. His blood was sent to the RRaT, and it did confirm his renal function was worsening. This was a clinical assessment, which really there was nothing massively exciting about it, apart from that he was clinically dehydrated. So that's what I just said. That was the conversation with the son, and then the following, so we rehydrated. So the following day, the following day, the rapid response nurse went to see him. She felt that he deteriorated even further. The son really wanted a hospital admission, and so the compromise was we said, look, let's get West Call. So West Call support our service out of hours and over the weekend when I'm not there. So they phoned West Call. The GP came out, really good, really nice mannerisms. Assess the father. It's really important this because it makes a massive difference to the way the relatives perceive the treatment of their family. So she's assessed it, turned around to the son and said, "There's no evidence of infections. Your father's dying of his end-stage renal failure." And within so the son got peace that an attempt had been made, and the father died within 2 hours. So none of these anticipatories which were put into place were ever needed. He died peacefully in the care home. And the son knew what was going on all along. And it was quite nice, because I think this outcome would have been a lot different if his advanced care plan had been reapproached. So those are the three. I thought it would be nice to type that. And once again, for West Core, they had a custom case of our advanced care plan on Adastra, so they knew what was going on when they went out to see him. I think those are our cases. Yeah. So if you have any questions.
The first case was Scouts was a bit annoyed, so after you put the care plan in place, are they now in a happier place?
Well, no phone calls to Scouts have been made. But it was really sad to see the fact that the care home got themselves so worked up and so distressed about what do we do, and nobody really addressed why they were panicking. And it is, you've got to think, some of these residential homes are just run by carers, they're not nurses. So they're encountering situations which are out of their depth at times, and if they know that they're supported, it just works so much better. Yeah, exactly, but they still put in the complaint to say that you called us. So yes, I agree with you. Yeah, exactly. I think they were correct. I think the care home were correct to do what they did, but they were getting in trouble every time they did it. And
but they often call as well to protect themselves and also for the family.
Yeah.
They feel that they're doing something for the family. So.
But it was, what was really nice, having that sit down, having the carer or somebody from a care home representative, and having the family. And we have done some advanced care planning with residents, by the way.